Hi, everyone. Steve Olmos here, and just want to welcome you to this webinar on Nuvola. And I guess we'll get started with a beautiful picture of Hawaii. We took that just back in August, and wonderful meeting with all of our centers around the world. Just for some of you that may not be familiar with me, my practice was limited to treating chronic pain and sleep breathing disorders for over 30 years. 13 years before that, I was a general dentist and spent a lot of time just learning all the different concepts and trying to basically find out what really works on a daily basis when a practice is limited to these kinds of things. And from that, I've developed protocols on how to treat and how to implement this in a productive way into practices and make them either limited in that way or add to general dentistry of all specialties. And these are the docs that I've personally mentored all over the world in these concepts. So that we could set a standard of care, if you will, for how to go about treating adults and children for these kinds of problems. And so that's what I want to review a little bit today and let you know that our courses in education span the world. Last year we were in South Africa and did a residency there. It's really quite fulfilling. If you haven't been to South Africa, it's quite a lively place. And it was great, yeah, being able to bring some of these concepts and treatment modalities from that meeting. We are now going to have a center in South Africa, so we should be getting that organized in the next week or so. So I'm pretty excited to move to another country and keep this education process and support of protocols um, um, spanning the world. This is annually we get together as centers and we share knowledge, we share practice management, we share all sorts of things with the top educators in the field and contributors. This is last year in up in Lake Tahoe. The picture I started with was our retreat just this year in Hawaii. And but what I wanted to center on is our retreat a couple years ago, where we introduced Nuvola to our centers. And the man right here in the middle is Alessandro Carafello, and he is the developer of this technique. He's an MD, DDS, orthodontist in Italy, and he's just come up with a brilliant technique. And honestly, over my 43-year plus practice, I've never seen anything so amazing and simple in my life. And I've done a lot of ortho, I've done a lot of techniques that I want to share tonight. But this is truly remarkable. If you haven't investigated, you can go on their website and take a look at some of the videos and cases and things that they have posted. And basically, it's a aligner system in combination with a device that develops the maxilla and really in amazing short periods of time for people of all ages. Okay, and so again, for adults and children, and that's pretty amazing. We can start kids as early as age 4 with these development processes, and as you'll see tonight, the simplicity is dramatic, and also the speed at which things happen. Okay, so let's start out with kids. Well, where does OSA begin? Well, it begins before birth. If we look at the fact that sleep disorder breathing occurs with a prevalence of 15% in healthy, obese, pregnant women, and 50% high-risk pregnancy. So every other high-risk pregnancy is related to some kind of hypoxia from mom not being able to breathe. And so that's really amazing. If we had better screening at that point, just think how much easier childbirth would be. And of course, the children themselves and mom and all the consequences. So we should talk about that a little bit. Back in 2017, when I was president of the American Academy of Craniofacial Pain, we hosted the seminal figure, Dr. Christian Guilleminault from Stanford. And, his concepts and thought processes were that we need to restore nasal breathing both day and night as the ultimate treatment for OSA. And so that really helps us understand, well, what is the origin for a lot of these issues? Because we know some of it's neural, our sensitivity to CO2, loop gain and arousal threshold. But then we also have P-crit and muscle tonus. And so those things come together, and we need to have a comprehensive plan as to address both of those situations. And so, well, how do we screen for children before they're born? Well, looking at face angles, this is something Dr. Guilleminault was talking about, that with the retruded mandibles and maxillas, because essentially our skulls have been shrinking. So this is an X-ray of a 19th century child as compared to what we're seeing now. And as all these structures are less than they should be, we have a high increase of respiratory problems. So he says that what we really need is an inferior facial angle about 65 to 69 degrees. If it's less than that, then we're likely to have some kind of respiratory problem. So there are screening tools in place, and there's consequences for not treating these problems. So some of the things that we see in the medical literature are as a result of untreated sleep breathing. We have preeclampsia, gestational hypertension, gestational diabetes, and severe morbidity. So preeclampsia or hypertension is quite dangerous for mom and baby. And this is diagnosed as a blood pressure 140 over 90 millimeters of mercury on 2 occasions, at least 4 hours apart. This is abnormal. And we have all sorts of signs and symptoms, excess protein in the urine, severe headaches, changes in vision, abdominal pain, nausea, vomiting, decreased urine output. And so we see that there's impairment in liver function and also fluid retention in our lungs. So these are all very serious consequences of not breathing, for which we should say that all pregnant women should be screened for apnea. And what happens in the hypoxic placenta is that we have these significant, what we call fetal normoblastemia, significantly more prevalent in sleep disordered placentas than non-snore controls and women with OSA. So basically what that means is that these cells are immature. And because there's an inability of the bone marrow, and these immature cells are released into the vascular system with the inability to carry oxygen because there's not sufficient enough hemoglobin. So basically, these kids are hypoxic, so all their cells in their body are screaming for oxygen, and that's how they're starting life. I mean, you can imagine. So these kinds of problems result in kids being small, that they have decrease in cognitive function. So we see that with verbal learning scores and performance scores that are reduced for these kids. And of course, they have early birth. So, you know, we understand a lot of what we need to do for these kids, but then they're born. Okay, so if you have a child, because you have to understand, for adults, every other adult in the world has OSA, and those are statistics that have been validated through PSG in recent studies. So we understand that if every other adult, that means that they were children at one point, and therefore kids are going to have the same prevalence. We don't see that in pediatric populations because we don't screen, but every year those numbers keep going up, just as they have been for adults ever since we started figuring out that not breathing was a big thing. So we wonder about kids with OSA. Do they get systemic inflammation? Do they have heart disease like adults? And so I was hosting a series of pediatric courses at the University of Tennessee some years back, and we invited some of the top people like Layla Gazelle, who did a presentation that showed us that, yeah, you know, kids have the same kind of mechanisms. The hypoxia causes vasoconstriction and increased right ventricular load, and you get systemic vascular inflammation or oxidative stress. You have the same kind of negative intrathoracic pressures. But what really gets you is the arousals. The disturbance of sleep. So not necessarily not breathing, but the fact that you're awakened because you're labored from it, not fully awake, but disturbed from sleep, brought from deeper to lighter sleep. And this causes oxidative stress, which causes thickening of the blood, which then in adults and children can lead to cardiac disease and stroke. So kids have the same mechanism. And if we understand that, then we would understand risk factors. So this is something I found a couple years back in the New England Journal of Medicine, talking about childhood cardiovascular risk factors and adult cardiovascular events. You know, so what are things that we should look for? And with all this literature that we see that's comorbid, you know, with cardiovascular disease and breathing problems in kids, they don't really look at that. They're looking at the same kinds of things they do for adults: body mass index, high blood pressure, cholesterol levels, triglyceride levels, smoking. Okay, nothing here is talking about the fact they can't breathe. Okay, so and that's worrisome. You know, why aren't cardiologists screening adults and children for sleep breathing problems? I mean, that's the number one reason why we're dying. So you would think that that has a high prevalence rate. But there are simple things that can be done to improve the situation. The more narrowed your nasal valve is, first point of entry, the more extraluminal pressure to close your airway. So that's called the Starling resistor model. And so we understand that by having patent airway, nasal airway, we're going to be able to breathe better and reduce the collapsibility of the airway and lessen OSA. So, but there's really simple solutions, something called Rainier and Vivere, which is basically just reshaping the cartilage with radiofrequency techniques and shrinking swollen tissue so that we're not reliant on nasal sprays. And so it's a very simple procedure. This is me having that procedure done. It's done under local anesthetic. It takes like 10, 15 minutes tops. And you walk out of there being able to breathe. And you know what I came to find out, besides the fact that I could breathe better and my apnea was less, is how it corrected my cervical pain problems I was having. So as you can see, my nose is all plugged up here. But if you look at the third cervical vertebrae, you can see how it's subluxed and how it basically pulling the tissue in because I have to use my mouth to breathe at that time. However, 1 week later, after having the nasal surgery, you can see how I've uprighted, okay? And now the vertebrae has come back into place. Now this isn't being pinched between C3, C4 anymore on me, so I don't have to take Motrin for my neck problems. So understanding the mechanics of breathing in an orthopedic way, you'll understand how we can affect posture by changing breathing. This is in the sleep literature, talking about how obstructive sleep apnea is related to these kinds of pathologies, and basically showing you exactly what I just showed you on me, about the subluxation at C3, okay? Well, I think this is wrong. I think they use the population of people with apnea, of which I'm one. However, my neck changed and I still had apnea afterwards. What changed is the nasal component. And I think that they haven't realized that pretty much everybody with OSA has some kind of nasal impairment, and that is the mechanism, because you have to sublux to open your airway, just as you do in CPR. But I don't think we realize that these things can happen in kids. So here's a child and already developing this kind of neck. And understanding that posturally you have to make these changes in order to be able to breathe properly, and understand, well, what's the consequences of that besides neck pain? Well, facial pain. Through our center network, we have published this paper because I wanted to know, does the nose have anything to do with facial pain and TMJ issues? And if so, what kind of nasal pathology might that be? So, so what we did, and I think, let's see, I've forgotten, I think we over 1,000 patients in this study. And what we showed is that we looked at nasal valve compromise, or the first point of entry, deviated septum, soft tissue hypertrophy here of the vomer, concha bullosa, and inferior turbinate soft tissue hypertrophy. Which one of these things, or any of them, have anything to do with facial pain, muscle pain issues? And so when we looked at the data, the most common deformity, if you will, of the nose is first point of entry. Nasal valve compromise is the greatest pathology in frequency. How is that related to facial pain? What we found is that if we ask the patient, hey, TMJ pain, we didn't find any relationship in that way, because that's the patient not really understanding what TMJ is, because they lump headaches with intracapsular problems, with muscular problems. So they just say everything that hurts in my head for whatever reason is a TMJ issue. Whereas when the doctors actually examine the patients and diagnose them, they diagnose them with facial and cervical myositis, so inflammation of the muscles of the face and neck, and inflammation of the joint capsule. When we actually had a diagnosis significantly correlated with these nasal obstructions. In fact, what we found is that if you have nasal valve compromise, you have a 7 times greater risk of having the muscles in your neck and face hurt and be inflamed. So 7 times a greater risk, okay? And I don't know of any other comorbid relationship that has a higher relationship than that. So we should appreciate what it is that we're doing with developmental orthopedics and orthodontics. I'd like to thank all the centers that participated. That's one of the things we can do, is we publish, because we collect data in a standardized protocol. So it makes it easy for these retrospective analysis to go back and look at what we did. So we talked about children. Let's talk about how we would handle an adult. Okay, I'll give you a for instance. Here's an article that I published in the Journal of Orthodontic Practice some years ago. And it was a gentleman who came to me with facial pain, jaw issues that he'd had for years, and he'd been previously treated, and a chiropractor had sent him to me. So I treated him, and this is the before and after. And I'll show you what I used to do in order to accomplish this, but I'm going to show you a whole easier way to accomplish it than what I did. And certainly it's quite dramatic how his distorted cranium was made more symmetric in this process. But a dentist previous to me, because I practice in San Diego, and this gentleman was in Arizona, so he had to drive 6 hours each way to come see me for relief, because the previous dentist had used a mandibular advancement device for a number of years. And we know after 12 weeks of using that type of device, that you're going to have growth in the condyle and the fossa. So that's why we see posterior open bites. And so he was complaining of jaw pain, headaches, neck facial pain, eye pain, and he had some sleep breathing problems as well that we identified through our intake. And we saw that you know, you wouldn't think a young man you know, slender young man, a BMI of 22.8, you wouldn't think he'd be in the category of somebody that has OSA, but you'd be wrong if you didn't know what to look for. So this is the occlusion that he presented to me with these issues. And again, because his jaw was held forward, and he didn't get any relief from that. So you need a really more comprehensive approach to handle these kinds of cases. You see the severe pathology in his nose with the deviated septum and the concha bullosa of the middle turbinate that had pneumatized and is blocking the airway. So looking through the analysis here, we didn't really see any osteoarthritic changes in the jaw, but he had a lot of inflammatory problems. So he had bilateral TMJ capsulitis, facial and cervical myositis, and I suspected a sleep breathing disorder in addition to the nasal obstruction. So we decompressed him in the daytime because he couldn't eat. You know, he was going to choke with that situation, and a nighttime appliance to prevent his jaw from protruding and keeping his nasal valve open. And we used our decompression therapy. We used medication regimen. We used laser, MLS laser from BioResearch, and nutritional supplementation. We sent him over for a sleep study and an ENT for nasal evaluation. So we treated him for 12 weeks and resolved 100% resolved his jaw pain, headaches, and neck pain. And so by that time, we had gotten a sleep study and find out that he has an AHI of 18, which is moderate obstructive sleep apnea, and an RDI of 41, which is severe. Okay. But he had no symptomology after the 12 weeks, which is our normal term of treatment, 10 to 12 weeks. So now he's doesn't have any of the issues anymore. And likely in our technique, if he hadn't been treated previously, he could have been restored to his original occlusion. He would have been just fine with some nasal surgery and then treating his apnea. But I had to treat this malocclusion now, okay? Which means basically we needed to develop the premaxilla and do some transverse expansion. So we put this position in the phonetic, which we published to show that it reduces collapsibility of the airway and also decompresses the jaws. And that's the technique, how we got him out of pain in the first place. So now we're dealing with this. And so we say, okay, we're going to then expand and transversely hold the vertical, and then we're going to develop the premaxilla. So we did that through a series of devices. So we start out kind of linear, then we go to more three-dimensional techniques, more Alf-like stuff. Got his wisdom teeth out of there so we could close the bite, and then just continue to asymmetrically expand so that we could restore symmetry. But as you can imagine, and we got some very nice results, as you can see, and you can see the differences in the Ceph tracings and Nato model of how we were able to accomplish that with very normal jaw relationships. So this is where we were starting from, and this is where we finished, and normalized the deficient maxilla, as you can see, moving 8-point. So that helped open the airway. That helped uprighting him. This is his posture when we met him. This is at 12 weeks of phase 1 where we resolved it. We only had to do the dental treatment only because the mandible had been moved forward. But after the orthodontic treatment, you can see he's now an inch taller, okay, because of the uprighting. So that's what we're trying to do, develop the maxilla to kind of fix these nasal valve issues. But he still needed surgery for that concha bullosa. And so we sent him off for that surgery. So this is superimposing the skull. The blue is the originating part. The bone colored is the finished CBCT that we superimposed here. So you can see that this is a unilaterally developed skeletal relationship to take an asymmetric head and make it symmetric. Okay. So is that possible? Yes. Yeah. Can you do it on adults? Yes. I'm showing you that that's possible. Okay. But at the end of it, we reduced his AHI down to 9.1. And so then we were able to, even though his BMI went up, so he's actually heavier now and older, but has a lower AHI. So at that point, we made him a FDA-approved appliance, type 12 nylon diamond digital orthotic appliance. So this is this appliance, as I say, is FDA cleared to treat apnea. With that device in place, we were able to get his AHI down to 1.1. And if you want, that could be his retainer, if you will, because we have full coverage. And his nadir was 97.2. So we were able to accomplish all those goals, but it took quite a bit of time. It took a couple of years to do that. What if we could do that in a fraction of the time without having to resort to all those devices and all those things? And that's what I'm here to tell you tonight. There's an easier way to accomplish this. So, so what's our technique? Well, there's expansion techniques. When do we start? Do we do it early, at 2 years of age? How would you do it? And what are the mechanics? Would you use something fixed, removable? But the point is, everybody wants to have development. And if we're thoughtful, we want three-dimensional development, not simply just transverse. And we need to actually develop that premaxilla as well. So we understand, and some people think that it's necessary to split the palate. I'm here to tell you, I have never done that. And I can show you incredible volume increases in nasal flow from the development that I'm explaining to you. And if I had the techniques that I'm talking about tonight, the treatment times and the ease of accomplishing those things would have been so much easier for the clinician and the patient. So then you get into, okay, you've got different mechanics. Do you expand slow? Do you do fast? Do you do mechanical expansion? These are all things that people would look at to understand what the differences are between surgical and non-surgical expansion. And the fact is, can you, the MARPI, the SARPI, and all this sort of thing. And is that superior to doing it in a non-surgical way? And can you accomplish these goals? And so, so I'd like to go back to an old paper, 1998, talking about maxillary expansion. You would expect this paper to be talking about children, but in this paper about expansion, they're talking about young adults with a mean age of 27 plus or minus 2. So you're talking about almost 30-year-olds that had significant reduction in AHI, apnea-hypopnea index. And so they're showing you some very traditional expansion devices, but they use them on almost 30-year-olds. So, so my point is, if you're able to do it on adults, you should be able to do it more effectively on children. And so their data shows that that is exactly the case. So that's why we can say, well, okay, we want to expand the maxilla. But is it just that? Is it just a transverse expansion? In my mind, no. In the case I showed you with the young man who had apnea, we started out linear transverse expansion, and then we went to a 3D. So, and that's what you need to do to restore symmetry in an asymmetric starting point. And so understanding that, what exactly is the measurements that we can equate a maxillary expansion to? So this is a great paper written by a good friend, Mili Motro from BU Orthodontic Department. And what he did is he looked at CBCTs, and he had a special software that would measure the volume, nasal volume, before and after treatment of expansion, so that he could quantify exactly, how much increase there is. And so we had three different groups, ages, because it ranged in age from 8-year-olds to 22-year-olds. And so there were kids in between that he would use a hybrid type expansion. So basically it looks like this. So your traditional expansion for, your mixed dentition, the 8-year-olds, and then of course for the older kids, the 22-year-olds, he would use implants embedded in order to expand. And then the kids in between, he had coverage with an expansion device. So basically, he's all types of expansion on all different ages. And here's what he found, is that for every 1 millimeter of transverse expansion, and that's linear, so that's not like a three-dimensional. So for every 1 millimeter of transverse expansion, you get 2.35% increase in nasal volume. And for every 1% increase in nasal volume, you get a 4-fold increase in flow rate. So you don't need to make big changes in volume to get very dramatic increases in flow rates. So you can imagine just a 6 millimeter development dramatically changes how you breathe through your nose. And here's the important part: it didn't matter what age; it was consistent through all populations. That's very important for us to understand. So that maxillary expansion leads to significant expansion of the nasopharynx, oropharynx. Okay. So we understand about this asymmetric starting point and symmetry. And that's where this paper in AGODO was published on the analysis of nasal airway symmetry after expansion. And they're talking about how the different groups help to get this significant increase. So maxillary expansion shows a significant increase in nasal volume, minimal cross-sectional width, and nasopharyngeal volume 2 years post-treatment when compared to a control group. And so the authors, the data was collected by Dr. John Walker, who's an orthodontist in Boston. He's a good friend. And he's done a huge population of this. And he presented that. So this gentleman here is Mile Motro that I just spoke of. This gentleman here is John Walker. This was a pediatric conference at BU, hosting some of the experts in the field. And so I was showing this case here so that we can understand how we might go about treating pediatric OSA, perhaps in a different way than we would treat adults. So now we talk about the fact that we can do this surgically, which is quite popular, the different techniques, but again, it's still transverse. And so if you're going to be effective in treating OSA for these groups, you need to move that maxilla forward. So it isn't just the transverse, which we know is going to increase nasal volume, but to affect it in terms of the airway. And we teach this in our pediatric OSA courses, the difference of how we treat. So in 2012, the official journal of the American Academy of Pediatrics talked about the fact that all children / adolescents should be screened for snoring, and that it should be screened for snoring, and polysomnography should be performed in children and adolescents with snoring and signs and symptoms of OSA. Has that been adopted by pediatric physicians? No. So here it is, 12 years later that we've been talking about this, but they're slow to actually implement. We have a pediatric sleep screening tool that we collaborated with Judy Owens from Boston Children's Hospital and Harvard, along with the ACP. that has been submitted for publication. So that's a 6-year study that we were working on that will be published in the Journal of Evidence-Based Dental Treatment in this year. So we're excited that we'll have greater awareness. What do kids look like that have OSA? Well, they have this type of body posture. Kids that grind their teeth, okay, which is very much comorbid with sleep breathing problems. So when we increase nasal breathing, as we see here in the dural oral rehab, that head posture changes with kids that grind their teeth. So a more anterior downward head tilt was found in the Bruxis group with statistically significant differences compared with controls. So we can see that if we expand the maxilla in mouth-breathing girls, we'll see an uprighting of the head. The influence of respiratory function on craniofacial development head posture has been demonstrated previously. And so by expansion of the maxilla, we see is capable of increasing nasopharyngeal airway adequacy in girls, and this leads to a decrease in craniocervical angulation. So we understand in the orthodontic literature that this has been around for a long time. And we see that in other publications. This is a European Journal of Orthodontics that basically is saying the same thing. So we understand these relationships between head posture and nasal breathing and mouth breathing. And so those are certainly topics that we want to address, but the underlying OSA in another subgroup is also of interest. Okay, so we can see that pain, airway, all these things all are comorbid. But there's one more thing I want to share tonight that you may not be aware of, and that's the high incidence of ADHD, which now is 1 in 9 kids in the US are diagnosed with these issues. And oh, excuse me 1 second while I make a little change here. There we go. And so this is scary. That ADHD is an ongoing expanding public health concern. According to researchers studying the disorder, 1 million more US children were diagnosed in 2022 compared to 2016. So we're seeing greater and greater populations of kids with these issues. And so the presentations are a little different between boys and girls. Boys are going to be a little more hyperactive, more impulsive. Girls are going to be inattentive, more daydreaming, lack of focus on a particular task. So they manifest the problems differently, but the origins seem to have a similar, they have a similar origin. So the report found that nearly 78% of children that are diagnosed with ADHD had at least one other diagnosed disorder. And very often we see the behavioral contact with anxiety and developmental delays, and autism and depression are frequently observed. So these are highly comorbid relationships, and we see that that's increasing. So sleep disorder breathing likely exacerbates ADHD and may actually be the origin of the problem. And we see this in the psychiatric literature, how these are comorbid. So breathing disorders, attention deficit disorders, autism. And we see that because of the awareness and the increase of breathing disorders that we're seeing these cognitive issues. And so we see that this one study, they had over 3,000 kids aged 5 years old. 25% of them had a sleep disorder breathing. And we see that these kids with sleep disorder breathing have a higher prevalence of hyperactivity, aggressiveness than children who don't have these issues. Similarly, a review found that children with OSA had a high rate of attention deficits. 95% up to 23% children with ADHD had OSA. So an understanding that a meta-analysis reported that youth with sleep disorder breathing were at higher risk of presenting with ADHD symptoms, and that these symptoms improved with adenotonsillectomy. Yeah, temporarily, but we know that adenotonsillectomy, as its effect on improving breathing, relapses 75% of the time after 6 months. So those are not long-term solutions. But let's take this another step forward. Let's look at the current literature. So sleep problems in children with autism spectrum and attention deficit, how do those compare? So we see that sleep problems are commonly reported among children with ADHD and ASD. However, it remains unclear how the disturbed sleep could potentially exacerbate these symptoms. And well, obviously, particularly REM deficiencies and in the cognitive part of sleep where we assimilate what we've learned, and obviously the fatigue of not having restful sleep will present with these kids having this symptomology. So the results of these analysis indicate that both groups, sleep problems mediate the relationship between symptoms, communication skills. So sleep difficulties have an indirect partial effect on communication challenges of these kids. In multiple regression analysis, sleep problems and symptom severity explain 44% of the variance in structural language, 35% of the variance in pragmatic language among kids with ADHD. For autism kids, sleep problems and sleep symptom severity, 22% in variance in structural communication, 49% in variance of pragmatic. So a high level of overlap. Okay. This investigation highlights the need of considering sleep disorders when assessing communication skill in autism and ADHD, given its indirect influence on the domain. So understanding sleep dysfunctions of both conditions and their repercussions is crucial to develop adjusted interventions. Now, here's the end point of this, which literally is the end point. And this is probably the saddest thing that I've read, is the increase in suicide rate in adolescents. So this is from the American Academy of Pediatrics, talking about the fact that suicide is the second leading cause of death in 10 to 24-year-olds in the United States. Okay, so number one would be trauma, but would you guess that suicide of children would be number two reason? That's like scary. I mean, homicide is a distant third. Okay, so the rates of suicide have been found to be as high as 42% in children and adolescents with intellectual disability. Adolescents with physical, intellectual, learning disabilities have a higher risk of suicide compared with non-affective adolescents. That's terrifying. What are the consequences of not treating breathing disorders? Individuals with neurodevelopmental disorders, including attention deficit disorder, learning disabilities, autism spectrum, are at higher risk for suicide attempts. Youth who reported disability disclosed 3 to 9 times higher rates of suicide attempts compared with youth without a disability. When we talk about treating breathing disorders, people, oh, kids are going to sleep better, they'll do a little better in school. How about they don't kill themselves? Okay, let's get real about what's going on here. And I don't hear people talking about this. Perhaps many of our dental professionals are not reading the psychiatric literature. I do. I read the medical literature. I read the dental literature. And so these are the guidelines for the pediatric physicians, talking about the things that they should be looking for in to prevent suicide or address it. But I read through all of these things and there's no mention of screening for sleep disorder breathing. And I just showed you the high comorbidity and all the literature. So that's the frustration we have with a lot of people who supposed experts that people tend to read the literature of their specialty. They don't read other people's, and that's where a lot of these things kind of fall through the cracks. because if it doesn't make it into, your specialty literature, which is, let's be honest, very political, that the public doesn't get served. And that's what we're trying to do here, is get the message out about why and how frequent these problems are. So let's talk about this. So children with autism have an earlier onset of suicidal thoughts and behavior. Almost 1/3 of children and adolescents with autism who report suicidal thoughts aged 8 years and younger. Okay, now is that like making you crazy? Because that makes me crazy. And so they're looking at using this data from the Mental Health and Suicide Behaviors Questionnaire. And this was screened over 28,000 children, okay? So that's a pretty good sample size, okay? And that data set comprised almost 1,000 caregivers of children and adolescents who are diagnosed. So this is really good data. And so the unexpectedly high frequency of suicidal thoughts and behavior among children with ASD who are 8 years or younger is particularly disturbing given the lack of validated suicide risk screening tools and intervention. So this isn't, I think, in the dental literature, common knowledge, okay? So there's an article that I just wrote for the Journal of Orthodontic Practice that will be coming out in their latest edition, which I think is in another week or so. And so I wrote a paper on screening and treating pediatric OSA, explaining a lot of the things that I just covered, but also talking about some of the new technology and tools we have, including Nuvola, and how we can use laser therapy in addition to these techniques to accelerate and improve the results. So look for that, and that will help you better understand how we can put all this together and have a really good result. Okay, so let's talk about Nuvola, because I wanted to kind of set the stage so you understand the kinds of things that we can affect. Because some people might look at this as just ways to make more room for teeth to grow, or not understanding the neurocognitive component as well as the respiratory and the orthopedic. But if you understand all that, then you can appreciate this gentleman. So I visited his office in Italy. And because he's an MD DDS in Italy, your dentistry is a subspecialty of medicine, and as a result, then you have a medical background, so you have an MD, and then you DDS, and then you have a specialty of orthodontics on top of that. So when I went to his office, it was really strange to see an orthodontist looking at people's posture, examining them orthopedically, looking at skeletal measurements, very different than anything I've seen in North America. And I was quite impressed. And I was amazed at his cases, so much that we developed a relationship through the parent company of Nuvola, which is Biomax, and they hold conferences every year. This one was in Verona last year, to which I spoke to, I don't know, 600 or 800 dentists to explain all of these concepts and the things that I'm sharing with you. And I was just there in May this year, giving a little more extensive information about how I go about treating people with chronic pain and how we can merge these concepts with Nuvola. And we had a number of people, as you can see, everyone with their headsets on, with the interpreter from my presentation for that day. And we had a number of our centers travel from Australia, from the US, to come and share our understanding of how these things work. So let's get back to how does this work, okay? All right. So the aligner system you're familiar with, but the mechanism is something I'd like to talk about right now. So you can see that there are projections from the liner trays, and they engage this device, which is to be used about 30 minutes a day. So compliance is very good with this technique. And engaging those pins as the person chews on it. It doesn't have to be 30 minutes in a row. It could be 5 minutes here, there, whatever, just 30 minutes throughout the day. Um, is really just a brilliant concept. When I first saw this, I was just floored because compared to the other things that we do to accomplish these kinds of expansions. So basically you wear the aligner, for 24 hours a day, but you only use the Freedom device and chewing on it, as I say, for 30 minutes per day. And you change the aligners out every 10 days. And so the mechanism basically is using these aligners and these pins to take the vomer and use it as a piston to basically three-dimensionally unravel and do all the things that I showed you I did on that gentleman, but without having to affix any kind of fixed appliances and have to deal with all those issues, especially if we're talking about kids. And so looking at this from a functional way, I have to say I was quite impressed. And the time it takes to do it is a fraction of what it is that we're doing with other devices and the complexity of all those things. And one of the cases that he was showing on this gentleman, in order to deal with a class 3 situation, I was just quite impressed. I just hadn't seen anything that could handle these things in such a short period of time. So I bowed down to Alessandro. I said, "This is really quite amazing. It's brilliant. It's brilliant." And if we combine these with our two techniques, then I think and that's what we've been working over the last 2 years, and that's why the course that we're going to be having in November in Pennsylvania is the first in North America. Our centers were the first to use these techniques, and we've been doing that for about a year now in the States, a little over about a year and a half now, I guess. So, and we have these also for children. So we teach this when and how to use these devices for kids, and we have flow charts on how to address that, and I have flow charts on how we address this with adults, and basically our techniques of treating pediatric OSA by advancing a point with certain techniques, as opposed to using Nuvola to three-dimensionally develop. And some of these, because we start kids as early as age 2 with development techniques and myofunctional techniques. So, so understanding where you would use a technique like this, because it's pretty universal. Just think of the compliance, and just think of all the stuff that you don't have to glue in kids' mouths or adults, and that you don't have to manage with the frequency that you would have to. And so I just think, from everything I've seen, and I've been all over the world, literally, I have never seen anything this comprehensive, this easy for both the clinician and the patient. So compliance is going to be so much better when we combine Nuvola with lasers and myofunctional therapies. It's dramatic. And so those are some of the things that we want to share with you. So I've spent some time in Italy, and on one of these trips, I made it out to Sardinia for an orthodontic meeting. It was the 50th anniversary of the orthodontic dental school there. And so I got to meet this woman, Simona Busso, who is an orthodontist in Italy, and she did an amazing presentation on how to treat children with speech difficulties using these techniques. It was really, really amazing how she was able to help these kids and restore the cranial distortions and the class 3 situations that we had there. So it was really, really cool. I was honored to have gifted a book for the 50th anniversary, 1976 And 2016, they published this. With Antonio Coppola, who is the president of Nuvola. So it was a really exciting time. And I'll just share with you a little bit of a presentation that she did for our centers. Let's see here. There we go. And just to give you an idea, we won't go through the whole thing, but she's basically showing how she corrects these, malocclusions and open bites and the deficiencies and the skeletal issues and nasal function that is restored and her mechanisms, and how we handle class 3 situations and all the problems that we deal with. And when to start the treatment. So there's a timing to it based on root length and the deciduous teeth. So there's a lot of information that you're going to get in this course. We have a 2-day course coming up on how to handle these situations, open bites, this kind of thing, posterior, anterior, making these kinds of changes in just a short period of time, which I find just simply off the chart. There's so much more to share with you in the upwriting of these patients, just physically, so that you understand the mechanisms. We talked about that. And then, of course, just also finishing with a beautiful smile. So we've got function, we've got orthopedic correction, aesthetics, all done at the same time. And just think, if you can do that at an early age, what a difference in the rest of life for these kids. So it's truly amazing. You have to do it to believe it. But look at these cases that she's doing, and look at the orthopedic corrections and things that we see. I'm just incredibly impressed. So again, if you'd like a little more information about what we do, so I wrote a book on airway management, kind of give you a short overview of the kinds of thought processes and things that we're teaching. And so also wanted to share with you this course. So this webinar here was to give you a little bit of background, because we have a 2-day course. I'm going to do the entry part of it in order to explain, well, how do we get people who have these orthopedic issues and facial pain and breathing problems, how do we get them stable, and for adults, and then how do we transfer them to Nuvola, and how do we handle children in these situations, secondary. So we can go over all the different types of cases and ways that we can do that, so that we have consistent improvement. Tiffany is going to send you all email of everybody who's attended tonight's webinar. I want to thank you for taking the time. I know you've all had long days. I hope you found this interesting. I am just blown away. So I can't wait for November 1st, because spending 2 days with Alessandro is you'll have to see for yourself, because he is an amazing person. And I hope to see you in Philadelphia. On last note, I'd like to ask everyone for their prayers for all the people in Florida that are having to deal with this hurricane, and God bless them all. So thank you for your attention, and hopefully we'll see you in Philadelphia. Thank you.